All right. Hi, everybody. So today I'm going to be talking about conjoint analysis. Part of the reason we're doing this is because we are running a conjoint analysis with a larger group of people on what aspects of point of care testing do you want or do you prioritize most. So what is conjoint analysis? It is a way to analyze revealed preferences based on the assumption that stated preferences, which are assessed through things like Likert questions, are inherently biased. So rather than asking you, what do you prefer, we give you a choice, and what you choose tells us what you prefer. This is used to identify what features of a given product or service are most valued by users. It was originally created for marketing research, but has since been adapted for use in human and animal medicine for a variety of purposes. That includes determining what type of things you would prefer in your diagnostic tools, how to prioritize different diseases for public health interventions, and eliciting expert knowledge to identify the most important risk factors for incursion of emerging diseases. There's a particular type of analysis called choice-based conjoint analysis, where we have combinations or profiles of features presented in a series of choices, and respondents are then asked to choose which choice they would prefer. As a brief note, there is actually a lot of discussion and disagreement between different fields on what to call this type of analysis. We are calling it conjoint analysis because that is what other people in the veterinary public health field call it, but you might also see it called discrete choice analysis or discrete choice experimentation. So just so you know, the type of analysis is consistent, but what we call it is different. So how do we perform this analysis? We identify the attributes that we want to analyze, for example, sensitivity, specificity, or ease of use. We then identify levels within the attributes that we are interested in, so high versus moderate specificity, or easy versus moderate versus difficult specimen collection. And then we select our experimental design. The first type of conjoint analysis is full factorial. This is rarely used because it presents all of the options possible to the respondent. Our design that we're presenting today has 6 attributes. 3 of them have 2 levels and 3 of them have 3 levels. This means there are 216 possible combinations, and we just don't have time for you guys to sit here for the next 12 hours and consider 216 possible point of care tests. So what we're using today and what we'll use in our larger study is a fractional factorial design. So this presents a subset of the options to the respondent. We do make sure that we have orthogonality, which makes sure that the attributes are statistically independent of one another. And we make sure to have level balance. So each different level is presented the same number of times. So we aren't presenting or introducing bias by only presenting options that have moderate specificity. So why are we even doing this? What is the point? While we were doing that literature review that Sol was mentioning in the last presentation, we found a lack of data on accuracy and operational utility of many proposed and in development point of care tests. So we aim to identify which features of these point of care tests are most valuable to you as the end user. And this will then be used or can be used to inform future research on point of care tests. The full questionnaire, not the one we're doing today, but the one that we're presenting to a larger audience, has 11 attributes, including sensitivity, specificity, connectivity, or the ability to use Bluetooth or Wi-Fi to upload results instead of having to send them manually, ease of specimen collection, which would be using chew ropes to obtain oral fluids versus actually having to restrain a pig and get blood from it, cost, user-friendliness, how much training does your user have to have before they can use the point of care test, rapidity, equipment requirements, does it require a benchtop full PCR thermocycler, or does it just have a small cartridge like a lateral flow test? What kind of power input does it require? What is the storage temperature requirement? And does it have built-in quality control? So what is it actually going to look like? We are using Qualtrics to present our point of care test analysis or assessment survey. The attributes are located on the leftmost column. The order of these attributes is randomized per respondent, and this is done to, again, reduce bias. If we had them all immediately in the same order, a lot of people would look immediately towards sensitivity and just use that to make their judgment. We then have profiles of the tests on the middle and right column, and the respondent is asked to choose which of these two presented point-of-care tests they would prefer. Each choice or set of profiles is presented independently. We ask that you only consider the 2 point-of-care tests presented when making your choice. So today, for our shorter analysis, we are only assessing 6 attributes. Cost, which is the cost of the test itself. For the purposes of this survey, we ask that you ignore other costs associated with point-of-care tests, such as cost of refrigeration or transport, just the actual cost of each test per animal. Sensitivity, how well does this test identify true positives? Remember, if you have a low sensitivity, you may have you have a higher risk of false negatives. Rapidity, what is the turnaround time from obtaining the sample to obtaining the result? User friendliness, again, this is how easy or how much training is required to use the test. When we say low training is required, we are implying that this is usable by a layperson with minimal training. Specificity, how well does this test identify true negatives? Again, as a reminder, low specificity increases your risk for false positives. And then also ease of specimen collection. How easy is it to obtain a sample? The easiest, of course, would be using a chew rope to obtain oral fluids. And the most difficult that we are assessing would be obtaining blood, because you would have to have somebody restraining the hog, you have to have needle, syringe, and your blood tubes. So that is the most difficult type of test most difficult specimen we are assessing. And then what is this actually going to tell us? What's the result? This will tell us which attributes and levels are the respondents prioritizing over others. It also can tell us what does an ideal point-of-care test look like according to all of you. And then which levels are adding utility to a point-of-care test? Well, when this particular thing is added, even if it's not what you prioritize most, maybe it still is increasing your value in that point-of-care test. So that's what also we'll be looking at. If any of you are interested in reading more about conjoint analyses or perhaps running your own, this QR code links to a user guide put out by the WHO on how to perform conjoint analysis. And as you can see, they actually do call it discrete choice experimentation, but it is the same type of analysis. All right, so that is the end of what I'm going to say for now. Please use your phones, go to this QR code, take the survey located there, and then at the end of this session today, I'm going to be presenting the results of what you guys have submitted on that survey. So, all right, thank you. While we're also filling out the survey, does anybody have any questions or questions on how to do the survey? This one over there.
When you mention the sensitivity levels, what are you actually aiming for in terms of level of detection? What do you class as accurate and acceptable?
So we have 2 levels of sensitivity and also 2 levels of specificity that we're evaluating. We have high, which was 90%, I believe, and then moderate, which was 80%. We're not assessing lower sensitivity and specificity because our assumption was people aren't really going to prioritize lower sensitivity and specificity. But part of what we're trying to assess is at what point will people accept a lower sensitivity or specificity based on other attributes of the test.
And what do you, I mean, in general, what are you aiming for? I mean, 50 copies, 100 copies, 1,000 copies, what's acceptable?
We're more looking at like diagnostics, so false negative, false positive rates rather than the analytical sensitivity and specificity.
Okay.